Hello, everyone. We are super excited to be here for another session of the Learning Salon. For those of you who haven't seen us in a while or are joining us for the first time, the Learning Salon is a platform, or rather it used to be a weekly platform. Now it's a bi-weekly or weekly, depending on the kind of season now that we're in hybrid world, where we discuss contentions and bridges between artificial and biological learning. We have a very interdisciplinary audience, as you know, from neuroscience to psychology, philosophy, artificial intelligence, machine learning, computer science, linguistics. We have a lot of disciplines. So if you have any questions during these sessions and you're not sure about something, please put it in the chat and we would address it. Or if you have questions to the speaker, put it in the Ask a Question area and you can ask it to the speaker, and please vote on each other's questions. As always, we do not tolerate hate speech or any kind of harassment. So if something goes on, we will give a warning and then manage it so you can feel safe. We encourage everyone to ask their questions. Disagreement is no problem. Disrespect is a problem. So we always encourage people to disagree with each other, even intensely, but without disrespect. Another thing I would say is students and early career researchers are very, very much encouraged to ask questions. This is not a very high stakes question time because it's a short talk and a very long question period. So it's not very high stakes. If you ask a question, that's okay. And even if it's not very well articulated, we have time to hear you explain it again. So this is not a bad time to try it out if you wanted to ask questions and you were sometimes maybe worried about it. Oh, Jasmine, I'm so sorry you were directed to another talk. Unfortunately, something is wrong with Crowdcast when it sends out the emails. And I apologize that some of you might have been directed to the wrong session. I tried to bring some people back from the other meeting. I will try to do it again. I think Melanie left the correct link also in the other meeting. Another thing I want to say, most of us connected on Twitter. And this idea started on Twitter, and now Twitter is exploding. There was a revolution in Iran. There are so many things that have happened since the last time we had a salon. If anybody wanted to chat or needed support, also reach out to us privately. Okay, without further ado, and John Krakauer, by the way, is going to be here soon. He's in a meeting and running to a laptop as we speak. Our speaker today is Quentin, who is, Quentin, is it Huys? How do you pronounce Quentin Huys. I've always been worried that I need to pronounce it in a different way. I wasn't sure.
Whatever way works.
And Quentin has been a person in the field of computational psychiatry that if you have heard anything about computational psychiatry, probably you've heard his name. You've seen his papers. Something that I really appreciate about Quentin's work is that there's always a very careful consideration of multi-step thinking, whether it's in somebody with anxiety, in making the wrong choices because they're not considering things that are far enough, or whether it's about decision-making models that he uses. I'm very excited to hear your talk. And I will not take too much time. Usually we do a very informal introduction. Feel free to add anything that I've been missing as we listen to you. So maybe you want to try sharing your screen. So we see if it works out. Perfect.
Does that work?
Perfectly, yes.
So I can't see you anymore, but oops. No.
If there were any questions, I will just sort of on mic and let you know. Huh.
Well,
maybe we should.
Sharing or not? No. No. Wait. Let me try again. Something's happening. Okay. You can see my screen now?
Yes.
Okay. Try again. Can you see my screen now?
Yes.
Okay, cool. Okay. So thank you very much for inviting me here. My name is Quentin Huys. I'm at UCL, and also at Camden and Islington NHS Foundation Trust. Okay, so today I'll give a very, very broad brush, quick overview over kind of a way of thinking about the different approaches in computational psychiatry. Yeah, just a very broad overview, really more of a way of starting to think about it and hopefully of stimulating a bit of a discussion. So before I start, my disclosures, I receive editorial fees from Elsevier. I work with a couple of startups, Aya Health, Alto Neuroscience, and I have a research grant from Core Health. Okay, so when I talk to clinicians, and I appreciate there aren't that many clinicians in the room, but when I talk to clinicians or lay persons about, computational psychiatry, they often ask me, well, why? Why would you want to approach something like emotion, something like, relationships, something like hallucinations? Why do you want to throw equations at that? And so the way I think about it, and what's really been maybe the motivating factor between approaching it like that, is the notion of function. So I'm interested in what happens in illness, and I'm interested in treating illnesses. Now, when we think of illnesses arising from an organ, it's always useful to think of the primary function of that organ. So take the heart. Now, one symptom of heart disease, an important symptom of heart disease, is shortness of breath. Shortness of breath is about breathing. It's not really about blood. Now, obviously, if you know about the heart, you understand it's a pump. And if you know that a pump maintains gradients, then you also know that if you turn off the pump, the gradients will dissipate, they will change. And that means that fluid will go into places where it's not meant to be going if the gradients are maintained. And that's how you can understand how heart dysfunction can lead to something like shortness of breath through an understanding of its function. Now, obviously, the heart is an organ made of cells, and there's lots of cellular problems that can arise, just like in any other organ. And some of them are, have certain commonalities across the different organs. And so, indeed, the brain is made of cells, and there are some cellular, disorders that can happen. You can have a stroke, you can have cancer, etc. But the things that are really special about brain illness have to do with brain function. And so what's the function of the brain? The function of the brain clearly is to compute, to, process information and to change how information is processed as a function of what information was processed in the past. And that's really what sets it aside. So presumably, there are a number of different illnesses that we will not understand unless we understand some aspects of the function of the brain, the relevant computational aspects. Right. Okay. So what I'd like to go through today is to go through just 4 different kind of computational, let's say, domains that have shown a lot of, promise. That have been applied in terms of computational psychiatry. And really, they are dynamics, inference, learning, and very broadly approximation. And this is a broad term that stands for many things, really. So dynamics relates to one equation, namely a differential equation. Inference relates to another equation, Bayes' rule. Learning relates to a third equation, namely the Bellman equation or reinforcement learning. And here for approximation, which stands very broadly for, I think, supervised learning, here I've just used this equation. So let me take you through these 4 and just give a taster of how these have been useful in understanding different aspects of mental illness. So let's start with dynamics. Oh yeah, and so I guess We can think of maybe the top three as maybe theory-driven approaches, where we try to, understand, build kind of concise models of brain function. And the one at the bottom is maybe more related to, data-driven understanding or prediction. So really, the 4 points are that dynamics matter, uncertainty shapes beliefs, that we learn from and for rewards, and that data can lead to understanding. So let's talk about dynamics. Now, dynamics really, and dynamical equation relates a change in a variable to some sort of function of that variable. And this is something that is very, very, very common in many aspects of mental health, and particularly in many models of mental illness. So for instance, if you think about, the way psychotherapists or psychologists think about panic attacks really is as a system of differential equations. So the way we think about it is that panic attacks, so what are panic attacks? Panic attacks are states of severe anxiety that really come on kind of out of the blue. People feel like they're just going along with their normal life and they're kind of okay and happy, and then suddenly this severe anxiety kind of hits them. So how does that happen? And so one theory that's been very useful has been that that the idea is that is kind of the following. Imagine you have some palpitations, and your interpretation of those palpitations are that maybe something's going wrong with your heart, and maybe maybe these palpitations mean that you're in danger, or you might possibly even be about to have a heart attack and maybe even die. Now that thought, that interpretation of the palpitation leads to anxiety. Anxiety itself leads to arousal, and arousal itself then promotes palpitations. And then you have this lovely kind of, positive feedback circle that just escalates. And so you see how palpitations, anxiety, and arousal can mutually excite each other. And all this is really a system of differential equations, where the change in palpitation is proportional to the arousal, the change in anxiety is driven by palpitations, etc. Now, dynamics are really powerful. We can produce many complex time-varying phenomena with even, just a few variables. And we know that they're computationally powerful in that they can implement universal Turing machines. Indeed, dynamical systems have been applied very widely to many different levels of analysis in the brain. So from the symptomatic level, we know that actually the learning systems, to return to in a second, they are a dynamic system. A lot of what we know about the guarantees of those systems come from their characterization as dynamical systems. And, if we think about ion channels or neurons or neural networks, they're dynamical systems. So the second kind of domain we think about is that of inference. Here is one very exciting example from Katrina Schmack last year, where they worked on hallucinations. Now, hallucinations, so hallucinations have to do with inferring that a stimulus is there when maybe there are not there. And so what Katrina Schmack and their colleagues did is that they used a very simple paradigm where people are trained to report whether or not, so they're trained to associate the stimulus with the presence of a sound, a faint sound. And then in the test phase, they have to report whether yes or no they hear the sound or not. And sometimes people will report that they hear the sound when they see the stimulus, even though there was no sound present. The tendency to do that is exacerbated in people who have had hallucinations in the past, who have psychotic illnesses, and indeed it correlates with self-reported hallucinations. Now, what she did is that she went away and translated this task to animals, to a mouse model, and so here the mouse had to kind of poke in a port to indicate that they had or had not heard the signal, and they had to indicate their confidence in having heard the signal by how long they were willing to wait for the reward in the port. So they indicated that through the length of persistence in that port. And so what is interesting is then they can basically look at this symptom in animals, and then they examined dopaminergic signals in the striatum, and found that indeed the false alarm rate, so the tendency of reporting a stimulus when there wasn't one with high confidence, increased with dopamine. They could produce this effect by stimulating dopaminergic neurons, and critically, they were able to then treat this effect by using a drug which is known to treat hallucinations and psychotic symptoms in humans, namely haloperidol. And so, what is this? So this is now a beautiful example of how we can take an understanding of a computational description of a symptom and use that to translate it to animals and really dig into the neurobiology. So that's an example of how maybe inference has been used to understand hallucinations. So then let's briefly move to learning. So this is, many of you may have seen this. This is a famous Bellman equation. Some of you will have seen this in a different form in terms of prediction errors, which are which derive directly from this equation. So here is one example where we have used reinforcement learning in a very specific clinical scenario. So the clinical scenario is that depression is very common, and it's often difficult to treat depression, but sometimes you can treat depression effectively with antidepressants. But unfortunately, when you've achieved that with an antidepressant, it turns out you haven't really healed the illness. Because when you stop the antidepressant, many people go on to relapse. The risk of relapse into the depression after stopping antidepressants is really quite high. And we have no good understanding of who does and does not have a risk of relapsing. So what we did here is that we used a very simple reward-effort trade-off task where we can apply reinforcement learning to measure decision-making. And from that, we then extracted aspects of the decision-making which were altered in people who were well, but who were on antidepressants before stopping the antidepressants. So this shows the willingness of choosing a high-effort option in this task. In this task, you have to choose whether to exert 20 button presses for 1 point or more button presses for more points. And so the question is, how often do you go for the high reward, high effort option? And you see that healthy controls go for this high reward, high effort option more than patients who were on antidepressants but no longer depressed. These are healthy and well, but they don't go for that option. And you can extract a parameter from this and see, and what we found is that this parameter then predicts whether these patients go on to relapse, a few months down the line after they've stopped the antidepressant. And this was a study which was run in 2 centers, and so we were able to use the data from one center and validate it in an out-of-sample setting on a different setting, and found that it predicted relapse in the validation sample in a different country as well. So that's one example of how reinforcement learning is.
Can I ask a question? Sorry. Yeah. What is the cognitive notion of this parameter? What is the kind of like for others who maybe thinking about it in terms of if this was an agent, what would be this parameter in maybe a functional, cognitive, or computational ways?
Which parameter?
The one that predicts whether they're going to respond or not. Okay, or relapse or not.
The parameter that ended up predicting response was really the speed at which people made a decision of whether or not to invest effort, and that was what predicted a relapse best. Actually, to tell you the truth, in this particular instance, what had predictive power wasn't actually even the model of the parameter, but it was just a pure behavioral measure of decision speed. The computation model, although it captured the data nicely, actually didn't have as good a predictive power.
Is that correlated with the severity of their symptoms in general, or no? Was that correlated with other parameters that could be predictive?
So severity, so these are people who are well, so they don't have symptoms in this particular scenario.
Gotcha.
So these are people who are well but want to stop their medication.
So let's put it this way: before they became well, would the severity of their symptoms or the dose that they are on, would any of these predict, or the duration, any of them?
No, none of those have any sort of predictive power. They haven't really traditionally. There's very conflicting evidence on whether it does. And in this sample, none of them predicted anything.
Thank you. Sorry, I forgot you can't see me. So I was making a thumbs up and I realized you can't see me.
Yeah, sorry, I can't see you. Yeah.
Thank you.
Okay. So then, so that's a third example of how these methods are being applied in mental illness. And so a fourth example here is also from the field of depression, and is from Wei Wu with Amit Etkin as work. And so what they did is they used data from a clinical trial which compared sertraline, which is an SSRI, an antidepressant, and placebo. So people were given one of these two, and then they went on to either respond or not. But before they were treated, they had an EEG. It was a very simple resting state EEG. And so what they did is they used a clever way of analyzing the EEG pattern and relating it to the change in Hamilton depression scores, as a measure of severity of depression, to find a EEG marker that correctly predicts the change in depression. So this is the true change that was observed, and this is the predicted change here. And so this was, so this they managed to extract a pattern which had a good predictive validity specifically for the response to sertraline, but didn't just predict that people were going to get better. That it didn't predict that people were going to. It didn't predict change in symptoms for those people who were on placebo. So if you train on the sertraline data and then test out of sample on sertraline data, you have good correlation between the predicted change in symptoms. But if you use that model, train on the sertraline data, but then test on placebo, there is nothing that's happening. And in principle, you can use this then to assign, to choose whom to give which medication to. So based on the sertraline signal, you could subdivide people into those who were likely to respond or not, and so you could choose whom to give it to. Okay, so these are four kind of domains of work where different approaches have been applied to different aspects of mental illness, and they really relate to different computational modes. So just to step back, maybe, why do we throw math at the brain? Really, it's about function. And so here I've just illustrated four different areas of function by, 3 or 4 foundational equations that relate to dynamics, to uncertainty, to rewards, and really to, maybe machine learning and artificial intelligence. So I'd just like to finish by thanking all the people who've worked with me in my lab and all my collaborators who've helped me over the years. So I think I'll stop sharing so that I can see people. Yeah.
Thank you so much. There is so thank you so much for this fantastic talk, and thank you for sticking to the time. Usually we ask people to be 20 minutes, but they usually go up to 30, 40 minutes. So thank you so much for sticking to the time. This was a very helpful introduction.
I can go on.
I mean, I wouldn't mind if you told us a little bit more about some of your computational psychiatry models, like more specifically, like I really like the aversive pruning work. I like cases where, there is like either behavioral measures or models to attempt to see people's multi-step thinking and how that gets influenced. So any of those works, or pruning, aversive pruning, or other kinds of pruning work related, anything that's about multi-step, if you have anything, I would personally love to see that. If you have slides, I mean, obviously you have the papers.
Let me just see if I have some slides in this talk that I can just quickly pull out.
People in the audience agree, so.
Let's have a quick look at what slides I have here. I mean, how much longer would you like me to talk?
This is a free form, sort of scenario. So also let me see if I can invite John again. It seems like for some reason he's here, but he can't join us. He can't see us, but I keep sending him an invite. Let me try again.
Okay, so maybe I can share. So these are, here are some slides that I still have here. So they relate to sign tracking. I could talk a little bit about sign tracking. Would that be of interest? And addiction?
Sure.
Okay. Oh no, I need to share the screen. I can talk about two things, actually. Let me talk about one more example of, I'll talk about two more RL type examples. So, okay, so one important type of treatment for depression, anxiety, personality disorders, and a number of other disorders, OCD, is psychotherapy. Now, psychotherapy, even in the 60s and 70s, there were many different psychotherapeutic approaches. And people were complaining that, there's so many different schools of psychotherapy, so many different ways of applying kind of talking therapies, that it's hard to know what's good or what we should do and what we should do for any particular person. And so there were a number of studies that tried to do what are called component studies. So they tried to take apart the different components of psychotherapy to identify whether maybe, there are some more important components or others. And so that has brought us, for instance, from cognitive behavior therapy, that has kind of separated the cognitive and the behavioral part. And that has found that, in many instances, behavioral therapy alone can be just as good as the combination of cognitive and behavioral therapy. However, it continues to be, it turns out that that's often been the result. So often, once you take psychotherapies apart, you find that really, you find similar effects. And there's one famous paper which described the dodo bird effect in psychotherapy research, and that, all therapies are maybe equally good. So the question then is really how to move forward. And so more recently, there's been more work focused on trying to establish what the causal factors are that underlie treatment response. So what is it that really mediates response to different interventions in psychotherapy? And again, although there's been some work in that, it continues to be a little bit unclear what the mediators really are of psychotherapeutic responses. And so, in a sense, this is a little bit strange, because we have seen a huge amount of progress in our understanding of human affect, decision-making, and behavior over the past, let's say 2 decades or so. There's been a huge advance in our understanding of the neurobiology of it, of the determinants of individual differences in these aspects. And so it's sometimes somewhat surprising that, or it's maybe a shame that some of these advances haven't yet really been applied or translated into, mental health broadly, but, psychotherapy specifically. And why psychotherapy specifically? Because actually, if you go back to the early work in many, many of the fathers of psychotherapy, often their thinking was really very strongly behavioral. They're very behavioral. It was about reinforcement learning, about helping people learn, about reinforcers, engage with reinforcers again, etc. So what we thought is that we'd kind of try to approach this. So see whether there is any mileage to be gained in applying these newer neuroscience, computational neuroscience methods to see whether we can understand the mechanisms of action of specific psychotherapeutic intervention. And so here is a very, very simple initial pilot study, which we did together with Jackie Gollan at Northwestern University. And what we did there is that we kind of went through the manual of behavioral activation and thought that, interestingly enough, the core components of behavioral activation match somewhat nicely onto core components of affective decision-making in humans. And so let me briefly introduce those. So this is a talk from Market Tartmasip and myself that's 10 years old by now, where we try to cross activation with reward and loss. So here it's on the face of it a very simple task where you're presented with one of 4 stimuli on the screen. So when you see a yellow stimulus, you have to press a button and you get rewarded. When you see an orange stimulus, you have to not press the button in order to get rewarded. When you see a blue stimulus, you have to press the button in order to avoid loss. And if you see the purple stimulus, you have to not press the button in order to avoid the loss. So if you give this to, healthy undergraduates, they're very good at pressing a button for money. That's great, right? And they're very good at, avoiding loss by avoiding to press a button. So they learn this quickly. And you see the learning curves here. This is over the trials. You see that they learn this very quickly. They start out pressing the button a lot. I guess, you come to an experiment, you feel like you have to press buttons. But where they're really challenged is in these kind of, conflict situations where you have to not press a button in order to get a reward, or where you have to actively avoid. You have to press a button to avoid a loss. And so why is that? So if you fit a standard, reinforcement learning model, a standard Rescorla-Wagner model, which says that, the value of an action is, proportional to the reward you got, to the running average of how much it was rewarded or punished, then, pressing a button here is just as rewarded as, go is not punished here, and as much as no go is rewarded here. So this, when you fit this model and then generate behavior from the model, it predicts a very symmetric behavior. It can't capture these poor performance here. So you wonder whether maybe it's just because people like to press buttons a lot, and maybe that causes a problem. But again, if you include some sort of bias, that doesn't really do the trick at all. What you have to include is you have to assume that when people are in a situation where they expect reward, that is activating. They press the button more. Whereas when they're in a situation that is where they expect losses, that's kind of inhibiting, and they press the button less than they really should. And if you include that, so if you additionally assume that people learn the overall value of the stimulus, and that the probability of emitting a go action is proportional not just to the instrumental value of the stimulus, but also proportional to the value of the stimulus itself. So they are likely to respond go if there's a positive value, even if go is the wrong response for that particular stimulus. If you fit that model, then that really captures the data beautifully. So in terms of depression, this felt like this was quite natural because behavioral activation really emphasizes these kinds of aspects. It tries to help people re-engage with the activating effect of rewarding expectations, and it tries to manage people's inhibition, people's maladaptive inhibition and avoidance in the face of aversive expectations. So what we did was that we gave people this task repeatedly throughout therapy, and we rearranged the therapy in an attempt to match it better onto the components of this task. And then we asked whether these Pavlovian process, so this value effect on choice, whether an appetitive Pavlovian process might change after this appetitive kind of component of the therapy, and whether an aversive component might change after the more aversive component of the therapy. And when we fit, and this is, a pilot study, it's a small data set, but we fit kind of, a mixed effects regression matrix, that a model that really allows for change after this specific intervention. We do find the expected effect of the intervention on the appetitive component, such that people respond better if they show more of a change in the activating effect of rewards. And we also see an effect in the aversive side, although there it goes in the opposite direction to what we hadn't postulated in advance. So what this kind of work maybe shows is, and maybe I'll skip this, what this work tries to show is that you can maybe use computational learning methods to try and understand the processes that are engaged by specific interventions in psychotherapy. So as one example, and should I go over another one? Or should we switch to the discussion?
I mean, if you want to. I just don't know why your screen became it's not full screen for us for some reason, but
oh, is it not? Oops.
Something else changed. Like they have changed the platform, the software for some reason, but it's not your fault. It's probably the fault of their platform. But sure, feel free. Yeah, if we can go quickly over one more example, why not?
Okay, so this is a little bit of more haphazard selection than I would usually.
You may want to have it.
Maybe unshare and then share again.
And share again, and also have it full screen if that's okay. It's very tiny.
No.
Oh, I think you.
Okay, oops. So I turned off the video. How do I turn it back on?
Like that.
Ah. Okay.
Yeah, no, it's still there. I keep pressing the focus screen, but it doesn't work. Can you press the focus screen on it?
Is it now in full screen?
Yours is full screen, but for us, it's a size of the same size as everybody else's face. It's not focused. It's not you. It's this platform. So please just have it full screen, and we're good. You can't see what's going on because you don't have two screens. So yeah, let's just go on, and we will move on to the discussion soon.
Okay, so here's another example. So this is from the field of addiction. So most substances that are addictive have some sort of impact on dopamine. We also know from work on reinforcement learning that dopamine is very critical in learning. And so obviously you kind of wonder to what extent these are related, right? So, you wonder whether dopamine's role in addiction might be mediated by its role in learning. And so here is a really interesting phenomenon that comes from Shelley Flagel. And so she went back to a phenomenon that's been described for a long time, namely kind of an individual variation in the reaction of individuals during conditioning procedures. So this is a situation where, a rat maybe is exposed to a Pavlovian classical conditioning, where a stimulus in one part of the box predicts delivery of food at the food port at another little place. And what you find is that animals kind of naturally self-organized into two different groups. Some will kind of hang out, kind of approach the sign, and we call them sign trackers because they approach the sign until they hear the food dropping, and then they will go and collect the food. Others see the sign and go straight to where the food will be delivered, and they wait around there until the food is delivered. And so these are called goal trackers. And so what she did is she recorded dopaminergic transients during learning in these animals. And so she found something quite striking. Even though these animals learn equally well, so in terms of the behavior, the extent to which they express this behavior or this behavior is very similar. But when you look at their dopaminergic at the dopaminergic transients, you find that these animals show classical signatures of prediction errors, in that the response to the conditioned the dopaminergic response to the conditioned stimulus onset increases over time, whereas that to the unconditioned stimulus decreases over time. In these animals, even though behaviorally they really do show similar performance, you don't see much. It's pretty much flat. So this is pretty much flat. And so interestingly, what you can then also do is you can give these animals a dopaminergic antagonist, such that during the learning, you don't see much behavior at all in either of them. So these are the sham-treated rats. These are the rats treated with a dopaminergic antagonist. So they don't do much. They're pretty much a chance. Then you take them off and look at what they've learned. And you've abolished learning in the sign trackers, whereas in the goal trackers, you really haven't affected the behavior at all. So it seems like there are some animals which show signatures of reinforcement learning prediction errors, and their behavioral expression of learning depends on dopamine, whereas there's some other animals that do not show this dependence on dopamine and don't seem to, and in whom the dopaminergic transients don't follow the laws of reinforcement learning and prediction error. So strikingly, it is the sign trackers, that are at risk for addiction on a number of different measurements. So what we thought we'd like to do is to see whether we can see something similar in humans. So we adapted this paradigm for humans. So you have to look in the middle, you have to fixate in the center of the screen for a few seconds, and then you observe a conditioned stimulus here on the left, which is followed a little bit later by an unconditioned stimulus on the right. And we thought we did this. We wanted to do this with imaging, and it's hard to get people to move around to the goal and the sign in the scanner. So what we did instead is we used eye tracking. So this is more closer to the orienting response, which in the sign tracking field hasn't always been a very robust measure of sign tracking. But we thought we had to give that a go to see whether we could get something similar, in humans in the scanner. And so what we did is we looked at, where people looked at basically, and then we kind of classify them. So those people who spent their time looking at the conditioned stimulus, we're going to call sign tracker, those roughly speaking, and those people roughly speaking who look at the look away and look at the unconditional stimulus, we're going to call them goal trackers. And so when we then, the assumption was maybe that the sign trackers really learn their expected value V from using prediction error learning. But what we wanted to do is also have some explanation of what the goal trackers do. And so what we thought they might do is that maybe instead of using a model-free learning, they really learn in a model-based way, and they build a model of the world. They build a model of what happens. So this stimulus leads to this kind of event, and this event has a particular reward. So they learn a transition matrix, a transition matrix and a reward matrix separately. So, so this then allowed us to build different regressors. So we have our traditional prediction regressors that look at the reward prediction errors. And then for the model-based learning part, you can imagine that initially the transition matrix from CS to US is flat, and then over time you can learn this transition matrix a bit like you learned this here, just that the driving term here is here's the reward, and here it's just which outcome happens, but not the rewarding nature of that. And so then that gives you a different prediction errors over time, which are uncorrelated, and you can examine that. And so what we did find indeed was that in the ventral striatum, we saw a correlate of the reward prediction error in those individuals that were sign trackers, but not in the individuals that were goal trackers. Whereas when we looked in an area that had previously been associated with learning a model, namely the intraparietal sulcus, we do find a state prediction error. So this learning of the transition matrix, and we find that in the goal trackers, but not in the sign trackers. We thought maybe we might see something similar in the lateral prefrontal cortex, but we didn't see any distinction there. Okay, so that's another example of how, so here what we've done is we've used an animal model of that links individual variation in the dopaminergic system to risks for addiction, and then we've translated it back into humans. We find a similar possibly variability in individuals, and so currently we're examining to what extent this relates to addictive potential to addiction. Right.
Thank you so much. Actually, that was completely worth it. I think it was very worth it to have that example. It was a great example. One question. So you just did in humans, you just did fMRI and not PET?
fMRI and not?
PET, PET?
Yeah, no, we didn't do PET in these individuals. No, we've done, or I've been involved in some PET studies previously. PET can be a bit tricky. It's very slow. It's a little bit hard to relate specifically to these kind of fast transients. You do see alterations in PET in addiction. You see it more in certain disorders than in others. You don't really see it in all.
So, and there is this, obviously, this idea of having different learning rates from positive and negative stimuli and having like different kind of reactions to them. So this was with obviously positive stimuli that could be addictive. Do you think if you had shock, you would see a similar thing? Do you think that model-based people would also be faster at avoiding it?
Yeah. So that's a whole bunch of interesting questions in there. So here, the speed of learning was the same. You didn't see any difference in, it's not like the goal trackers are faster or slower than the sign trackers. They learn behaviorally at the same speed, interestingly, right? Sign tracking, the aversive domain is a little bit, is different, behaves very differently, and is not just the converse of this. So aversive Pavlovian expectations really play a different role than appetitive Pavlovian expectations. Aversive Pavlovian expectations probably have more to do with avoidance, with maybe maladaptive avoidance behavior. And so they're, I'm not sure to what extent one can just take this around and turn this around.
Let me ask
we haven't tried to explore this kind of sign tracking in the aversive domain.
Let me try a different way, thinking of dopamine's role, etc. I wonder whether it's possible that someone, for things that are appetitive, they could be model-based, but for things that are aversive, they could be not be able to use the states. Or I'm wondering about that, basically. That's what I was wondering about, that you could have a different, or vice versa. Somebody is very model-based when it comes to avoidance, but they're not learning things when you give them something appetitive. So they can get addicted, but they're very risk-averse at the same time in usual contexts. I was wondering whether there can be a dissociation of how model-based someone behaves, whether things are positive prediction errors or negative.
Yeah, certainly. So you can move people around in terms of how model-based they are by changing the task, by changing the task. You know, if things change more, people tend to become a little bit more model-based. If things are a bit more slow, people tend to be a bit more, a bit less model-based. It can be a bit more model-free. So you can move that around, and the extent to which people deploy one or the other system is, you know, the fact that there may be even a stable individual variability within one task doesn't necessarily mean that that person can only deploy one or the other system, right? It might just be that they need more, you know, they have more of a tendency to deploy one system than the other. We know that some of this does, you know, probably does generalize across different domains, but yeah, we haven't done, I don't think we've done that much exploration of whether these parameters that we infer from one task or from one kind of cognitive, you know, probe, quite how well they generalize to different, to other probes. So for instance, if we take this, so, you know, one aspect of the work here was that we tried to relate this sign tracking to behavior in this two-step task. And so we did see some promising relationship there between these two, so that the sign trackers showed more of a, you know, showed less of, you know, less model-based kind of behavior there. Right? So that showed some consistency. But yeah, I think there is a lot of work to be done to understand, you know, kind of at the meta level, what happens when you go from one task to the other. What are the subtle differences between task settings that might or might not engage different modes of learning and of cognition? Did that answer your question? Or did
not quite, but that's okay. I think that my question was systematic differences in the probability of employing anything that's, let's just say, cognitive map-based or model-based, broadly defined, because I don't think the brain actually uses one-step model-based. I do think that that's like actually a rare situation. But whatever approach it is that separates rewards versus some kind of a map of the state space, I wonder whether there is a systematic difference within individual in how they would respond to positive versus negative, depending on their training, so to speak. That's what I was thinking. But what I understand from you is very helpful. You're saying that in general, it's easy to pull people in different directions with the context. Therefore, it means that there could be a difference, but we haven't systematically studied it. I will leave the question floor open to Melanie and John. I have a lot more questions, to be honest. So I'm going to open the floor for Melanie and John first, and then some of the questions in the chat. Reminder to everyone else, please add your questions whenever they come up to the Ask a Question area, and vote on each other's question, even if you don't have a question, so we know what are the highest voted questions to invite on screen or read for them. Also mention read for me if you don't want to be invited to screen, although it seems like the system is malfunctioning. So TBD if we can get people on screen. Anyone? Melanie, John?
Melanie should go first because she was here. I just wanted to say, hi, Quentin, hello, darling. And I really apologize desperately. I was doing this interview, what can I say? And then I couldn't get in. I don't know what the platform's like. I had to go to.
Neither could I, you know, I couldn't get in either.
But hello from Lisbon, and it's so nice to see you after all this time. I'm embarrassed.
It's even later there than here. Thanks. I was going to think I should bring a glass of wine, but then I refrained.
Yeah.
Oh, I did. Look, I did bring one. It's the only way I get to
go downstairs and get one.
I'm gonna need
Yeah, thanks
ahead,
for this.
Melanie.
Has all been fascinating. So I'm going to ask, kind of step back from the details and ask a very basic question, because this was my first encounter with the notion of computational psychiatry. And I'm still kind of wrapping my head around what that actually means. You know, we've seen computational neuroscience, which has many different dimensions, you know, trying to build computational models of neural circuits, or using computational tools to analyze neural data. But what do you see as kind of the big picture of computational psychiatry? And what questions is this new field trying to answer?
Well, I think there's two. One is understanding the computational mechanisms that underlie the treatments and possibly the etiology of illnesses. And the second one is using, advanced data analytic abilities to just identify useful patterns. Does that answer it?
So when the first one, understanding the computational mechanisms of treatment. That's what you just, I think that's what I heard you say.
Yes.
So what does that mean exactly?
Of the etiology, of the origin of the diseases.
Okay.
So I think that's what I was trying to outline at the beginning, right? Why do you want to throw maths at something like why do you want to throw maths at madness? That's madness, right? And so the argument would be that it's about the function of the brain. And so the brain's aspects, certainly, of the brain's function have to do with, are best understood in computational terms. And so unless we have a reasonable computational characterization, it's a bit like, trying to understand, we just need that, right? It's like, the bones, they have structural function. You can't apply the same kind of bone function to understanding heart, right? Because a pump, it does a different thing. And the brain computes. So if we want to understand illnesses that come from computation and kind of malcomputation, we need a bit of a computational scaffolding. It's just not going to work otherwise. I think that's the basic idea. Does that make that premise?
Yeah.
I don't know if you agree with the premise, but
yeah. I mean, that there's a lot of controversy in that statement, the brain computes. I mean, and what that means. But what I took from at least some of the things that you were doing is taking some ideas from sort of computational approaches to understanding inference and learning and applying them to psychiatric topics.
Yes.
And that brings me to another question. So most of the computational approaches to learning that we have in today's machine learning community tend to be quite like individual. Here's an agent. We're going to have this agent learn how to do some task, and we're going to see what kind of inferences and decisions it makes in the execution of this task. But I'm just wondering to what extent, in psychiatry, in psychiatric illness, it seems like there's a very big social component, sort of the way that the agent or the individual is embedded in their social environment. And so I'm wondering if these, the kinds of learning methods that people have addressed mostly to date in machine learning are going to lack that sort of social dimension.
Yeah, it's interesting. Yeah, so I guess there's two aspects there. There's social and environment. So there's two important words, I think. So one thing that becomes abundantly clear if you work in the field of mental illness, that mental illness really arises at the intersection of the environment and the individual. There are people with, quite severe mental illness that are able to function and be well in the appropriate environment, in supportive, in supportive environments. There are other people who, and traumatic stress disorders are probably one example, right? Who have a relatively, let's say, healthy, who are mentally healthy in a sense, but who live in an unfortunate environment and are exposed to an environment that is, extremely averse. The kind of, environments that the patients I treat are often exposed to are, far from what, many of us, hopefully, will have experienced. There are extremely averse environments. And so it is clear that mental illness happens at the intersection of those two. Now, what does that mean? I think that comes straight back to function, right? So just like the heart is going to cause shortness of breath, in certain situations, you're having mental illness in certain situations. You're not going to be short of breath if you're sat comfortably in a chair, but you're going to be short of breath if you walk up the stairs, right? And it's the same thing with mental illness. You may not have the symptoms if you're in the appropriate environment, supported, but you will if you move to an environment which is, one that, your emotional, affective, computational, abilities or tendencies are not matched.
Yeah. Well, I mean, I'm not an expert in mental illness, but my impression is that in many cases, it's very much interacts with abilities for social kind of social dynamics, social learning, social, development.
Yeah, so absolutely. I mean, social component is extremely important in mental illness. Now, again, why is that? Mental illness is not about the inability to, say, move your right hand, right? It's about higher mental function. Where is higher mental function relevant and important? It is often in managing and navigating our social networks. That is the hard stuff, right? It's the hard stuff where we need things like mentalization, theory of mind. We need to plan. We need to understand concepts, abstraction, communicate. These are complex higher mental functions. So it is not surprising that if there are deficits in these complex higher mental function, that the social setting is the one where we should see it early on and rapidly. I'm not sure that necessarily means that there is something, something, that there's a special, social brain area that's really specifically related to mental illness. I think probably not, right? I think it's more of an expression of the complexity and the demands that are placed on the brain by social situations.
Can I take a stab at what's maybe? So I totally see your perspective, Melanie, but I also understand Quentin's perspective. Let me see if I can translate somehow to both of you what might be missing from the perception, that the way I see it, but I might be wrong actually. So I think what Melanie correctly points out is first that she's just encountering this field. And I think one thing that I would like to say, as someone who's actually published in the Journal of Computational Psychiatry, I would say the same way, if we can do any kind of model for any kind of human decision-making, we can see which parameters we can mess around with to create the kind of behavior that a person with a particular psychiatric condition on that kind of task can do. Why does it matter that DSM-5 is extremely flawed and we don't have a very objective way of identifying anything, honestly? Why not find some behavioral components in some decision-making tasks that we know might have some validity in the world? For instance, aversive pruning, which is something that Quentin did. has to do with if you have if you start and you receive in the one step you receive negative reinforcement, but then in 3 steps this path is going to lead you to more reinforcement, then another path that doesn't have that much negative along the way. Which one are you going to choose? Are you going to choose the one that in 3 steps is going to benefit you, or are you going to prune the one that has any kind of aversive short-term outcome? And so I think that he very nicely sort of simplified what I just described into a very simple task with like a tree, and then you could see, and then like we modeled that, for instance, with a particular thing. So I think there's a lot of merit to it, and there's a lot to be done, because there is so much, as you know, there's like the 50 years at least of cognitive science using math, or obviously more, but the ones that we cite a lot at least. And it's extremely helpful to see how that translates. One example is someone else who we had here, Claire Gillen, who actually tried a number of different kinds of conditions and tried to see if there is a model-based task can dissociate very clearly one of them versus the other, and turned out in OCD, in obsessive compulsive disorder, not being able to act model-based was a very kind of identifying feature, for instance. So it might be helpful to identify these kinds of tasks and parameters.
If I may just interrupt you there.
Yeah.
If I may. It's not an identifying feature. It's not diagnostic.
Oh, yeah, that's fair. Yeah, no, that's not what I meant. Yes, it's
we need to be careful here with the words that we use.
That's fair.
And I think, you know, there are substantial limitations to DSM. There's no question, right? And to the ICD, etc. They're very limited.
Yeah.
They're particularly limited in their neurobiological or psychological utility, because they were not designed or conceptualized like that, right? But they do have other utility, and they do have other validity. So they have extensive validity in terms of, you know, long-term outcomes, in terms of predicting, you know, the onset of other, well, you know, certainly more than, yeah.
Sorry, can I say one thing?
It's a big topic.
Yeah.
Which
the term diagnostic wasn't meant in the clinical way. I meant, I use it in the way that we use it in, like, this is signifying of that, is diagnostic of, that's what I meant, just to be clear. I'm not a clinical person. I forgot that words have a different meaning to a clinician. I didn't mean diagnostic in that sense. I just meant that in this data set, it was particular to, you could say diagnostic, I meant particular to the OCD patients, that they didn't have the sort of the model-based component as much as the others. So that's what I meant, signifying particular to, that's what I meant, not diagnostic in the clinical sense. But just to come back to something that I was mentioning, so, and like there could be many different reasons why somebody might be having avoidance behavior. And if we have specific tasks that could maybe help us see on which tasks they are impaired, maybe we can do a better job of identifying what would be the kind of course of treatment that could help this person. For instance, it could be that I build wrong models of the world. And so when I make decisions, I make the wrong decisions. And this could be maybe I ruminate a lot and I replay negative things, and my models of the world are skewed towards disaster. Or it could be that my brain builds the right models of the world, but what I do is I cannot use that model at the moment of decision correctly because I don't have confidence in my decisions for whatever other reason. And so both of these two scenarios that I mentioned could lead to the aversive pruning scenario in Quentin's experiment. If you have the correct model, but you can't use it because you just think I'm a failure, everything I think is wrong, I cannot trust myself, so you never really make consistent decisions based on your own mental models. Or if you can do that part, but your brain is building the wrong models for whatever reason, right? So I think if we have behavioral experiments that could give us a window into which one might be the underlying scenario, it could help in figuring out treatment. I'm just using my words also carefully. I know I could potentially use a word that has a meaning in clinical psychiatry, but would that be fair, Quentin?
I mean, the hope is that by using these models and these formal descriptions, we get, we can link the symptoms to the underlying neurobiology better. Right? That's really what we're trying to do. And I think, I tried to give this one example of where we use, a model of inference, right, to study hallucinations when inference goes wrong. And then we're able to examine that in the brain, link it to dopamine, where we know that, certain dopaminergic drugs help with hallucinations, right? And so that's really the aim. It's really the aim of that kind of work, is to bring, mechanisms into the game. And mechanisms here have to be somehow about processing stuff. And the best, the most cogent description we have of that is a computational one. And so, examples like the pruning task, they're like one particular example of types of, computational, heuristics that people might employ to solve certain decisions, which may or may not be useful in certain situations. But there are many, right? And it's about trying to link them specifically to symptoms and to what happens to these symptoms when we treat them, when we alter these mechanisms.
It also offers a kind of a measurable parameter for comparing before, after.
That's the hope.
Other than, yeah, exactly.
That's the hope.
That being said, I want to also highlight what Melanie is saying. I feel like maybe, Melanie, this helped clarify a little bit the way the approach of the field of computational psychiatry. Melanie and many people on Earth, of course, are very correct, including myself, to believe that there are, in many circumstances, there is interlinked kind of relations to social dynamics as well as the circumstances. And you were mentioning this yourself also, Quentin. Melanie, I haven't seen many models that use these kinds of multi-agent approaches. I do think it's important in the future, especially when we are thinking about the resources. For instance, when we think about a child, it's does the child have a network, for instance? It's not just does the child have at least one parent to take care of or one person to take care of them, right? So I think that in the future, maybe these more, not just in terms of just the graph structure of the network that would be healthy for the subject, but also potentially what are the negative weights, like who are the people in their networks who are exacerbating some symptoms, what would be the coping skills they need to use for some nodes versus other. It would be very different. Obviously, if it depends on the spectrum also. Are you, for instance, are you anywhere on the spectrum of autism, for instance? That's going to exacerbate that. Or do you have anything to do with PTSD? That's going to be definitely having some social situations. Like, doesn't matter how much you test somebody on paper, they go to a social environment, somebody reminds them of something, there's going to be a trigger. It's not linear. It's very complex. I think we are very at the beginning of this, and Quentin is one of the earlier sort of people who have been working on this. I do think in the future there would be more approaches to this. Yale has been working on kind of interventions by looking at network dynamics, but not in the same way that computational psychiatry has done. But what you're identifying, given I know that the SFI has workshops on collective behavior modeling, I have papers in collective memory, so I know where you're coming from. And I do think there is a way forward computationally at some point to marry these different fields. But as far as I understand Quentin's work and majority of computational psychiatry work that I see in this journal and other journals is mostly on the individual. So it takes individual cognitive science and studies it in the context of mental health. Does that make sense, Quentin? Which kind of fields might
we don't do multi-agent work, really. I don't think anybody does that. I think I agree with you. There is a lot of work on social components of cognitive computational models of social decision making, of theory of mind, of mentalization, of planning in social context. That there is that. But I think that, so that does exist, but certainly not, I agree, not these not detailed or really very meaningful description of social environment. That is not
Great.
On the menu.
Thanks.
Yet. Maybe tomorrow.
We should let John ask questions since he's the closest to a clinician that we have.
He is one.
A clinician. I think I actually am a clinician, but that's fine. I was actually just running the units when I flew here.
I meant in psychiatry.
Yeah, no. So Quentin, I'm going to take a really big step back, right?
Great. Not too far.
Well, yes, I'll fall out the window. Is that what you mean?
Yeah. No, we don't want that.
So you know, I remember conversations way back when we were discussing, you know, neurology versus psychiatry, and what is the difference between those two clinical disciplines and the disease study, right?
You tell me.
Well, yes. So I think they are different.
I would agree.
And, you know, it's been interesting when you talk about mechanism, right? It's very interesting that you use the word computationally, right? I find that really interesting, right? Because mechanism in neuroscience has been very often about, you know, neuron A impinging upon neuron B, neurotransmitter being depleted or not. It's been very much about parts, components, pieces, right? And, you know, I think that you could argue that we know the mechanism of Parkinson's disease. We can say that you've got depletion of dopamine and substantia nigra and et cetera, et cetera, et cetera, right? And you can come up with computational theories of the problems that Parkinson's patients have. Loads of experiments have been done, assays of the kind that you're talking about, cute little tasks in the lab. Some of them have actually been inspired by rodent tasks, and you can do it on Parkinson's patients, right? And so then along comes computational psychiatry. We're going to do the same. We're going to treat it as a slightly more complex neurological disease, and we'll take some tasks, reduced tasks that can be done in neurological conditions, and we're going to do them in psychiatric conditions, right? And then we're going to go, oh, look, you know, model-based, model-free. It really sounds like the neurologicalization of psychiatry, right? And it is. And why is it working in some cases? Well, because a lot of the things that happen to certain psychiatric diseases over time, and most of the patients you see, let's say, are at steady state of their condition, they've algorithmized and habituated and automatized a lot of their problems. So you can sort of come up with a neurological version of their initial psychiatric disease, you know. And you mentioned, I think at one point, panic attacks. You're in one of your papers, it's very low level, you know, it's panicking, heart rate, and it all, you know, you kindle, you habituate, all those kind of things. But there's another view, and I think this is kind of what Melanie was getting at, and I'm not in a, you know, I'm not trying to put, you know, words into her mouth, but a lot of psychiatric disease is meaning-based. For example, there are people who have isolated delusional disorders. They believe that they are, you know, the next Jesus, or they believe, you know, that their significant other is cheating on them all the time. And they come up with very elaborate justifications full of meaning as to why they believe that, right? So your models have nothing to say about any of that, right? In other words, your models are the downstream assays of the kind of, and I use it in the broadest sense, habitual low-level behaviors that can result from these higher level origins. Okay, so this is all, forgive me for using this language, system one manifestations of psychiatric disease. It's the disordered algorithms that the psychiatric diseases have created, right? Hand washing, you know, maybe people started hand washing habitually because they thought they were going to get a disease, but eventually they just can't stop themselves hand washing. And the reason why they do it vanishes into the distance, right? So in other words, you are really showing very interestingly that there are psychiatric conditions that, you know, psychoanalysis and the Freudian Jungian tradition that tried to sort of use meaning and words and scenarios and stories to explain what's going on, in a sense, you're saying it's all a little bit ill-founded, because really, by the time you see the patients, they've developed these sort of subconscious, automated, algorithmic abnormalities that are very neurological-like, right? And in some of the tasks that you use are quite similar. So what I would argue is, in a sense, you've taken the psychiatry out of psychiatry and turned it into a subfield of neurology. Now, that's fine, because I do believe that a lot of the conditions that psychiatric patients have become subpersonal or traumatized habits that we need to cure. But there are some conditions, and at least in their inception, where I'm stressed, I had a terrible loss, you know, I believe that I'm the king of Spain, you know, I just can't help being anxious every time I go on a new date. That kind of meaning reasons that people give, you're in a sense dismissing.
No.
And I want to know what we're going to do about the system 2 version of psychiatric disease versus all this neurologification of psychiatry that you've done, which I don't mind, but you've just taken those sub areas of psychiatry that seem more like neurology, and your experiments sound like experiments that could be done on Parkinsonian mice.
Thank you for the controversial statement. So, you know, there are obviously a lot of, you know, distinctions we can draw, which may or may not be meaningful, between what is a neurological and what is a psychiatric disorder, and where does one start and where does the other stop. And, you know, Parkinson's is sometimes treated by psychiatrists, sometimes by neurologists. So I don't know whether the professional boundaries necessarily are so meaningful in terms of the underlying, biology, or
Okay,
even,
just so you know my position.
I'm not sure that's
totally disagree with that.
Interesting.
But it's good that you're saying it.
Well,
No interruptions, John. No interruptions.
So I think your point is that there is interesting stuff happening in the content, right? And so, true, there's no question that there is interesting stuff happening in the content of people's thoughts and people's misunderstanding or understanding or insights, or, you know, unhelpful insights. The question is, to what extent we can understand the processes that drive that content. Is it all entirely parochial and entirely, down to the individual? Is it really only the very specific story that they've come up with, and there is no similarity to anybody else's story? And the answer very clearly is no. There are learning mechanisms that apply to these stories and to these narratives, just like they apply to behavior, and so that's why these approaches have validity, both when you think about, when you think at a higher, more abstract level in terms of, narratives maybe, or that kind of content, as well as simpler, behavioral consequences. So when I see, when I take a rat, say, and I expose it to some sort of, aversive stimulus, a loud tone or something like that, and I take a human and expose them to some complex, higher level aversive stimulus, I don't know, being threatened with dismissal in their job, is very different, right? But the argument would be that the underlying structure leading to the affective, that there is a lot about the underlying structure of learning and affective reactions that is similar to those two, even though the narrative surface is very, very different.
But just so I may, but you see, this is exactly the move that I knew you would make, right?
Good.
So in other words, in what way can you have a rat that believes it's the king of Spain?
So delusions, I think I agree, are tricky, right? And
so how are you doing?
Delusion? That doesn't mean that, you know, all of mental illness is just delusions.
But I want to know what the computational psychiatry of delusions is going to be.
Okay, I don't know.
So why don't we, that's what I'm saying. I just wanted you to admit that, okay?
No,
so what I'm saying is
that tricky. So hallucinations work well, right? We can deal with hallucinations. That's not so difficult. I mean, it's difficult, but we've made progress. There are some interesting, you know, approaches to delusions. I think they're they're in their infancy, and there is some challenges around delusions.
Right.
So, yeah, delusions is something that I would.
Right. So in other words, content psychiatry is what I'm saying is what I'm trying to say is the areas where there's been traction is where the behaviors have become cached in such a way that one doesn't have to talk about content anymore. In other words, the content is no longer driving the behavior. It's more like a neurological condition.
If I may add, I don't think so, John. I see what you're asking. I feel like what you're asking is, how can computational psychiatry capture the phenomenal and the content aspects of mental illness? I agree with you. The phenomenal part and illusions, delusions, that could be a very good question. I would love to hear everyone talk about it. One thing I would say about the content, I think when you have a case where you have to think about 3 steps ahead versus 2 steps ahead, and if you don't take into account what happens 3 steps ahead, you're not going to make the right decision. That is a case where you have some minimal and controlled access to the content. Would you agree, John? That's not entirely cached.
I'm just saying that kind of content. I mean, look, I'm not trying to impose. All I'm saying is that the interesting thing about mental illness, diseases of the mind, is that they are disorders. Some mental illnesses are disorders of meaning, right? They are
totally correct. Yeah.
And disorders of meaning.
What's disorder? What's meaning? Tell me what is meaning. So let's formalize meaning. What is meaning?
Well, exactly. This is the same sort of move.
Okay, we can approach that, right? And I think there is ways of approaching meaning and formalizing meaning.
But I haven't heard it today. I haven't heard it today. That's what I'm saying.
I haven't spoken about it today. It is correct.
And when I look in the articles, all I'm saying is that what's interesting about mental illness, no one's going to try and do CBT or talk therapy to somebody with Parkinson's disease or stroke, right? You're not going to have a chat with their motor system, right?
No.
Now you can have
the CBT to make sure that you motivate them to behave, to move,
but it's
rehabilitation, which is
but that's second order to their deficit, right? Whereas you can chat with people with mild mental illness. You can combat their content by sending content from you to them, right? So you're operating at the level of content from the interlocutor to content in the mind of the patient.
Yes.
Now, in mental illness, that is not true. That's not true.
Higher level function of the brain.
Yeah, that's not true in neurology. Right?
That's right. Yes.
And I want to know where computational psychiatry.
One second. Does Quentin think what he's doing is neurology? I don't think it is.
I'm calling it the neurological part of psychiatry is what I'm calling it.
Why is it neurological? That's the part I don't get, because it has to do with making decisions and it has to do with how to change it. I don't see how it's I still don't understand why it's neurological.
You can have decisions made in spinalized animals. They can decide which, I've talked about the frog. It decides whether to use its left or right leg to swipe away acetic acid, and its brain's been removed.
But nonetheless, what Quentin is particularly working on, it has to do with more complex decisions, usually that requires something more than a reflex, something that's neurology is not enough for, you need learning for, right? That's the part I'm not...
What I'm saying is, what I'm trying to say is that a lot of psychiatry, and I'm actually a fan of this, turns into kinds of subpersonal sort of, phenomena that look a little bit like some higher level neurological phenomena. And I think that that's really interesting.
I see.
And what I'm saying is it's very interesting that a lot of what seems on the surface, and I think that word was very interesting from Quentin, surface narrative, is the idea that actually the real driver, the real place that you can assay and affect is actually much more subpersonal and neurological than you might think if you pay excessive attention to the surface narrative part of the condition. And I'm actually very sympathetic to that, right? And, you know, the example I've given is, you know, a student and their teacher seem to be getting into lots and lots of fights all the time. And everyone's saying, what's wrong with, you know, little Nathan? Why isn't he getting on with the teacher? And it turns out he's hard of hearing, and all you need to do is fix his hearing, right? So all that surface emotional turmoil was actually caused by a hearing deficit. And a lot of psychiatry is a what I'm saying is a lot of psychiatry is a little bit like that subpersonal stuff at the level of what the Quentin is dealing with is a little analogous to having your hearing fixed. And I think that's true. And you could misconstrue intervening between Nathan and his teacher at the level of their emotional fights. And all along, you'd been much better off fixing his hearing. And that's what is going on here. But there are content level psychiatric disorders that I haven't heard anything being addressed.
So I think that, you know, it's really disturbing to a lot of people that you can give somebody who thinks they're the king of Spain or Jesus, you can give them a pill, and that medication often fixes the problem, or can, you know, in some cases. And so the content part or the meaning part just kind of goes away. The sort of meaning part becomes neurological because there's this underlying chemical fix for whatever the condition is. And I guess, you know, there was a good question in the chat from Atta asking, you know, what diseases did we used to think were psychological or psychiatric that we now think are neurological? And it's kind of the goal of all of sort of science to reduce all the psychiatric diseases to neurology, or is that just never going to happen?
And just to your point, Melanie, I would say that is what this could sound like, right? And I know people will say that psychiatry is just more complicated neurology, higher functions, that kind of word is used, right? I'm not sympathetic to that. I think that there is something more than that going on. And I think that's exactly at the heart of this whole enterprise, is has computational psychiatry just become the 21st century's version of neurotransmitter psychiatry? So it used to be serotonin up, dopamine up, and it was just up, down. And now it's just a few computational processes that are up and down. We've just gone from one type of reductionism to another. And I think it works for certain subpersonal processes, but I am highly wary of it being able to go all the way to what many people thought psychiatry was about, which was content-based, strange thinking.
But John, one thing I want to say is
view of psychiatry, right?
One thing I want to say, sorry, John, listen, like some people study vision in V1, right? It's like telling them, hey, the brain is not just about V1. There is concepts, and it's like, yes, there is, but this person is working on V1. And in the end, when we have a larger view of the brain, we need that information about V1 too. I think of computational psychiatry as a huge field, and everybody would work on some particular subfield of it. I think your worry is a similar worry to what maybe fMRI was facing 25 years ago, which pretty much everybody was working in vision. Maybe you're saying, hey, you need to work on other things. And, you know, I'm not sure if your models will even work on those. Is that what you're saying? I'm saying, are you saying in principle, these models can never address?
No. I'm actually not trying to make any extreme statement one way or the other. I mean, I actually am glad that I precipitated the comment that Quentin just made. That's a very old-fashioned view of psychiatry. This is what every reductionist always says when it comes to any area, is that, and I'm just saying that. No, I mean, what I say is old-fashioned is that it's all it's about. I'm not saying it's there's much more to it. No, he said psychiatry is all about this kind of, you know, narrative. And I think there is more to it. No, right? I completely agree. There is that, and it's an important component, right? It's just, all I'm saying is it'd be nice if it was actually mentioned explicitly in articles about computational psychiatry. Call me back in 2 years. Yeah. Yeah, but why doesn't it ever get? What I'm saying is,
it's tough, right? It's tough, but now we're slowly developing the tools to address that, I think.
Right.
So call me back in 2 years, and maybe I'll give you some context.
Right, and all I'm bringing attention to, again, is I really like the work. I actually genuinely believe that there is, and all I mean by the neurologification of it, and I mean that either just because it's a clinical condition, is that I believe that there is a lot of stuff that bears a lot of relationship to what happens in the more behavioral aspects of neurology. And I think you'd agree, like Quentin, that there's a very fuzzy boundary between behavioral neurology and a lot of psychiatry, right? And there are residencies, as you know, where people do behavioral neurology and psychiatry. So in a way, this is behavioral neurology and really insightful. I'm just bringing attention to the sort of narrative, meaning, content end of psychiatry, which is a lot, and there are many books on psychiatry use the word mind. And all I'm saying is it would just be interesting to our listeners to know that there are hurdles, as you are now saying, which are very difficult. And a lot of people have a folk notion of psychiatry, which is more at the narrative, psychoanalysis, meaning, delusion end. And all I'm saying is I find it interesting that people in this field barely mention it.
Not yet.
We have a couple of clarification requests for this particular discussion. So one person whose ID is MY asks, please define neurological disorders. And Anna is asking, even though computational psychiatry is talking about dynamic processes, it seems to me that many of the descriptions capture mostly processes that seem to be somehow automated, reminding me of system 1 processes. Is that right? So it seems like Anna has a similar idea as John. And so I just mentioned that. And then I want to ask also what MY or Mai is asking, which is define neurological disorders. They say other things too. I'll just start with these.
So neurological psychiatric disorders are really defined by, what is treated by neurologists versus what is treated by psychiatrists. And so different parts of the world put that boundary in different places. And, I don't think there is very, I think what John is getting at, I think is maybe it's just using that as an example or as a way of, pointing out that there are aspects that go well beyond these simplistic models. So aspects of the human mind, which are complicated and rich and have a lot to do with details of content, of understanding of the world, of construing our world, that have consequences for how we experience the world and thereby consequences for maybe our affective functioning, etc. And they are so far beyond the kinds of models that I've presented here. There's no question. The kinds of models that I've presented here are very much in keeping with the kinds of models that we are also used for neurological disorders, which, are sometimes thought to be less related to that content. You get plenty of content in lots of neurological disorders, right?
But those are the ones that are less modeled.
And they are less modeled because it's harder.
Right.
So it is hard. I think those are hurdles, right? I think there is ways of approaching. So maybe in a few years you can call me back and I'll give you more details.
And again, Quentin, I'm really doing it more for didactic purposes because, of course, I can tell by what you've just said that you understand the distinction that I'm making.
Yeah, I agree with it.
I'm saying that if I hadn't brought it up, it wouldn't have come up. That's what I'm saying. And I think that is what I take objection to, is that one should also address those issues that seem to be very apropos at the real boundary between psychiatry and neurology, and they don't really get addressed. And I think it would be interesting, almost like a negative capability, to explain, well, why is it so recalcitrant to the same kind of approaches the more neurological end of psychiatry isn't? In other words, what is it that makes it harder? Why is it harder? Why isn't it succumbing as much as the neurological end of psychiatry? That sort of more meta discussion, because otherwise, I think a lot of people who are less aware of these distinctions will think that computational psychiatry is well on its way, right? And I just think that I'm not convinced yet by that.
Yeah, I mean, I think, you know, the question is, to what extent do simpler, you know, so take interpretation, right? So you can, interpretation is a complicated process, right? Which, you know, involves, you know, viewing an event within, you know, the context of a person's history and experiences and views and beliefs. So, you know, whether, you know, somebody who is not, you know, somebody who is, say, not used to scientific discourse can, you know, take the kind of questions we ask each other, you know, might interpret them differently, right? Different cultures have, you know, react differently to that. And so the question is to what extent we can understand those basic processes in simpler situations, right? And how far that brings us. And I think it's not clear, right? In many ways, we have, you know, there's been limitations, but there's also been successes, right? Now, you know, take hallucinations, for instance, right? So is, you know, judging that you've heard a sound when you haven't heard one, when there hasn't been one objectively, how related is that really to hearing a voice talking to you and telling you things? Don't know, right? It's kind of far away, really, right? But at the end of the day, if it involves the same kind of neurobiology and allows us to tap into the same neurobiology, then maybe there are some interesting similarities, and maybe you can use them to gather more insight.
So Quentin, to that point, I mean, now we're getting to the heart of a lot that happens at the Learning Salon. You know, that statement that, you know, they seem far away, but there's a similarity. You know, Melanie, in her wonderful book on AI, has a section where, I think Melanie can tell me if I'm wrong, where she explains the term that Dreyfus coined of first stepism, right? Where, oh, well, this is just the first step. This is the simple version that will get to the more complicated one. Now, the thing is that goes down like a lozenge. It goes down very easily. It sounds
That's not true. But we have plenty of effects, right? Plenty of successes. It actually works, right? So, you know, this behavioral activation, the notion that reinforcements are important for depression, for how depression is maintained and how you can treat depression, works, right? We can use that to treat it, done, right? We don't need to necessarily engage with all the details in order to have something very useful and that works. And it's, in a sense, I don't think it's just first stepism. It can capture something very meaningful.
I'm saying that there are times where you sounded like you were invoking first stepism in a.
I'm sure I was. Yes, fair.
Yeah, and there are other cases where I agree with you that at the boundary where psychiatric conditions become more subpersonal, system one-ish, neurological, they can yield fruit. I completely agree with that. That's what makes this boundary so fascinating. Please don't misunderstand. I think the boundary between the neurology and the psychiatry, and whether it's epistemological, historical, cultural versus ontological, is fascinating and really interesting. Right, but I'm just saying that sometimes I think there's first stepism.
Yes.
And other times I think
we haven't taken the first step.
Right, and I just think that what would be nice is to be able to create an argument why visual hallucinations and verbal hallucinations, are they really similar? Just because we call them hallucinations, or are that false friends, that similarity? And what kind of argument we have to make about meaning-based hallucinations versus visual ones? Could we flesh it out as an argument rather than just hoping that people go, yeah, that seems similar. Let's keep.
John, can I cut in with a potentially relevant problem that I'm working on that might bridge something here, and maybe not, maybe. And Quentin, this is something I wanted to ask you anyway. So I'm trying to figure out a computational RL-based model of rumination. And I've worked a lot in replay before, but turns out it's not so simple, because replay is not necessarily conscious. It's not the same speed as thought. It's like, 16 times faster than experience. It's always a sequence of experience, like directly there. But rumination is sometimes episodic. Sometimes it's part episodic, part semantic. Sometimes it's counterfactual. Sometimes it's semantic concepts that are related. So episodic or not. Another thing about rumination is it's always somehow related to self. Another thing is it's usually about negative content. So initially I thought, oh, I will have replay with a negative bias, and I think this is rumination. And then I realized, actually, no, if I'm talking about replay as what happens in the hippocampus, I can't do that. So what do you think about a potential computational model of rumination? And I hope that John can see this gets closer a little bit to content-based stuff. I mean, jury's out on it. John, like, let us know what you think, obviously, after Quentin.
Well, rumination is a complicated thing. I'm not sure I can deliver a computational model of rumination now on the flip of a finger.
But just like maybe explore the ways in which the complexities John is talking about would be present in such a model, and its differences from just replay, which is, you know, common across many species. Maybe that can acknowledge what John is looking for, the thing in mental illness that takes more than the replay model of a rodent in order to achieve. And it's more complex, it's multi-system, for instance.
So, all right, where did I start? So I think an interesting aspect of rumination has to do with metacognition, with beliefs about what it is worthwhile thinking about. Clinically, rumination often does, well, often is maybe a strong word, but clinically rumination does respond to metacognitive type interventions where you work, or, you know, they're kind of at the border of cognitive and metacognitive type interventions. So the cognitive type interventions, that you identify these thoughts, you understand that, you know, they cause you upset, and so then you learn to not think those thoughts. Now, what does it mean that, what does it involve, this notion of, okay, I'm going to choose not to think a thought, right? So this ability to control and exert some sort of, you know, agency over the contents of our minds is a complicated one, right? It's one that often has to be taught. And so that involves some sort of metacognitive aspects and some sort of defocusing or distancing from the ongoing thought process itself, some kind of, you know, view on that. So what's that in computational terms, right? And I think that's a meaty question. I'm not sure I have a very good answer to that. But I think this, you know, I mean, you mentioned the pruning. And so if we step back from that a little bit, what is pruning about? Pruning is about complicated situations where, you know, we're not able to think through all possible aspects of a problem, right? And so we have to prioritize, and we have to choose to think about one aspect or another aspect. Solving that problem, what we should focus on versus something else, is itself a hard problem, right? In fact, is itself a harder problem than the original problem. So it's entirely untractable. And so this is the kind of situation where we require approximations of some sort. We require some sort of strategies that may or may not be good to help us choose what to, you know, apportion cognitive resources to. So in terms of, you know, decision making, you can think about, you know, which aspects of the decision tree are you going to focus on and which are you not going to focus on. And so this brings us to these kind of meta reasoning or metacognitive type processes, which, you know, we can describe formally and try to understand formally. So we can try and understand the broad brushes of the nature of these issues or these processes. And maybe we can use some sort of understanding of that to guide our understanding of the kind of metacognitive aspects of things like rumination. So, you know, when I accept or start to, you know, understand that I can choose to not ruminate, and that if I choose not to ruminate, things will actually be better than if I choose to ruminate. That is an important kind of therapeutic process. And maybe that has to do with a change in these kind of metacognitive decision processes, this meta-reasoning. Now, we don't have a good handle on meta-reasoning and metacognition. We don't have a good formal handle. We don't have a good experimental handle on that. But maybe that's one framework within which we can think about them.
It's, you know, we had...
Sorry, to be clear, it seems like Sorry, what?
I was just going to say,
oh, I thought
we had David Better on. I mean, I don't know if you know David, you probably do. And we had a discussion about, he gave a whole talk about prefrontal cortex. And what it turned down into there was his main models were very hydraulic. It was
hydraulic.
Yeah, it was very much like your sounding. It was, we can't really talk about the representations content-wise, and David sort of admitted this. It was, how do you switch between A and B? We just take for granted that we have content A and content B, task A, task B, you know, multitasking, switching between tasks, top down. It was all the sort of train track switching that you do, given the content, we have no idea where it comes from and how to explain it, right? And it seems to me that you're doing exactly the same. You're saying, well, we can ruminate or not ruminate. I'm going to switch from wondering about how rumination itself happens to the switch between to ruminate or to not ruminate. So you've done a kind of bait and switch. You've basically gone from the hydraulics of doing something versus not doing something, rather than being able to explain the actual nature of what rumination itself is, right?
John, it seems like both of us wanted to say the same thing. Can I just I wanted to say in a shorter way, I was asking, I'm thinking about a model of rumination, what it is. You're talking about metacognitive control over it. Once we understand what rumination is and or model it somehow to show here is healthy, here is a rumination, then we can see that parameter. Okay, another thing can be the meta learning of that parameter either way, right? But first, I guess the thing is, can you maybe tell us if you think a model of rumination is possible? Not that you should give it to us right now.
Possible.
I think what John is saying, I'm not sure if I understand correctly. It seems to me that John thinks a computational model of something like rumination might not be possible. Is that what you're kind of saying, John?
I am saying that whatever that ends up being, and I wouldn't dare say that, but I would say you're absolutely right, that what I'm saying is, just like when David was on, you know, it's a little bit like the arguments, as you know better than I by far, right? When people talk about the difference between learning something versus explaining once you've finished learning how you actually, right? And
sorry, you just broke up. I didn't understand that.
I'm saying that, Tim Leary-Crapp and Conrad Koenig had this nice paper saying we may never know how the brain does something, but we may well know how it learns to do something, right? And so it seems to me that there's a difference between once you've accepted that there's something to be learned, you can come up with algorithms to get to it. But if you then ask, once it's done it, how is it actually doing it? It's a very different question. And it seems to me switching between ruminating and not ruminating is a very different type of computational model than a computational rumination itself.
Okay,
right?
So here's an example for what happens in rumination. In rumination, people ask, why are things bad for me? And so as a result, they find explanations for why things are bad for them. And that reinforces beliefs about why things must be bad for them. And that causes negative expectations.
Sure, but where does the notion of why come from?
Oh, it's very prominent in rumination.
No, I know, but what is why? What's the explanation for even asking a why question?
So it's an attempt at solving the problem.
But you see, you're presupposing, but all I'm saying is you're presupposing that people want explanations of things.
Yeah, they tend to, and when they ruminate, they tend to, mostly.
So do rodents want to know the explanations for things?
Do rodents want to? I don't know, you tell me.
No, obviously not, right? So what I'm saying is, the mechanisms of switching that you think can generalize from rodents to humans, and they may do, is a very different thing to saying that we would have a rodent model of wondering why something is happening, which would be, in my view, absurd.
I don't know. I don't know to what extent language is necessary for this kind of, you know, seeking. So why is about seeking explanations, right? Or establishing a model, establishing some sort of predictive model. I don't know whether language is necessary for that. Presumably not, because otherwise you can't have ballistic control, right? We have ballistic control. It does involve a model, a predictive model of the world. And maybe you could get these kinds of processes in that kind of a model without needing, you know, to ask a question. I don't know.
Right. So here's been the, I mean, this is again, honestly, the idea of the kind of models that are used in ballistic control being in some way related to coming up with an explanation of the kind that you were talking about. I mean, that is an incredible example to me of false similarity. That's what I'm saying. It's the word model being stretched across.
So tell me why. What's wrong with it?
Well, I'm just saying that the notion of, I mean, this is a longer conversation, but I don't think that models.
No, you're saying it's wrong. Tell me why.
I'm not saying, I don't think, first of all, that in the cases of ballistic control, we ever run a simulation, ever. It's a mistake.
Maybe that was the wrong
right.
Yeah.
Right. So in other words, model to me implies simulation.
Mm-hmm.
The notion of overt simulation is a very vexed one. You know, Ida mentioned replay. It's still an open debate whether there's overt simulation of trajectories in a maze that are then picked by an animal. It's very much what people want to conclude, but it's still an open question.
But it's an open question, right? We don't know.
Yeah, we don't know, but but every time we try and find it, it's incredibly recalcitrant.
It's recalcitrant, there's no question.
Whereas in humans, we can easily come up, I'm going to decide how I'm going to get from Queen Square to Charing Cross, and I can conjure up in my head the London map, and I can simulate my stops. We do it over and over and over again. So what I'm saying is to the degree that psychiatry is a disorder of some of those abilities to simulate and plan.
Challenging to live in animals. Yeah.
That's right. So right. So ballistic.
On the other hand, our brain has certain similarities. And our brain builds on a lot of the same.
As I've said many times in this program, Quentin, yeah, but one of the biggest fallacies is to believe that substrate continuity implies functional continuity. You can have functional discontinuities with very similar substrates. The one I've always told you, feathers for thermal insulation and feathers for flying look identical. Totally different functions. So in other words, looking at the substrate similarity is of no help.
That means, and exactly on that notion, you can take a simple model and you can apply it to different problems, and it does something else. That's exactly the point. Sorry?
But something else is the opposite of similarity.
Well,
How about we take a couple of questions from the audience and then continue if it wasn't too late for Quentin, because we don't want to like corner him and not let him go to sleep ever.
This is fun.
So it is very fun. And like, that's why we run this so much. And I personally like this a lot. So I'm really enjoying this. So Anna asks another question. Hi, Anna. We know each other from Berlin. We went to the same PhD program. In the review paper, you say that in depression, prior beliefs are thought to be biased towards hypotheses that make losses or punishments more likely. So that's the first part.
Sorry, where is this?
This is in the Ask a Question area. You can read the question if you want. If you click underneath the screen, Ask a Question, there is like a 7 number in front of it. The first question there is Anna. And she asks, in your review paper, you say that in depression, prior beliefs are thought to be biased towards hypotheses that make losses or punishments more likely.
Right. Yeah.
And she asks, I wonder how a computational model can explain why depressive episodes are temporarily limited.
Yeah. So, well, they're temporarily limited. So if you look at, so there's this man in Zurich. His name is Jules Angst. And he is now 94, 95, something like that. When he was 27, he recruited a cohort of 18-year-olds. He has mostly outlived the cohort of 18-year-olds, and he, followed them throughout his life. He looked at what happens if you have an index episode of depression. So you have one index episode of depression, and he followed these people up for the rest of their life and measured over the duration of their life what amount of time they spent in the depressed state. And so if you plot years since index episode against, amount of time spent being depressed, the line goes up straight. It's a straight line. There seems to be a constant hazard rate. If you have an index episode of depression, you will come back to depression again and again throughout your life. The rate at which you do so is higher if you have bipolar illness than if you have unipolar illness. But really, it is, to a large extent, a chronic illness. The fact that this is a chronic relapsing condition is really also why it is such a high burden of disease across the world. If it was just an individual episode, then really this wouldn't be, such a big issue in a sense, right? I mean, it'd still be an important illness, but it wouldn't have the huge burden of weight that it does have. So I guess, in a sense, I would argue that maybe we do need to think of depression often as of a chronic illness when it really is an illness. There are obviously situations, and this I think comes back to this situation where I talked about before, where, this kind of symptoms that come from depression really are at the intersection of environment and brain, so that you can get a depressed type syndrome in a perfectly healthy brain in certain situations, in certain environmental conditions. And maybe then it is a little bit, maybe then it recovers, and those people are maybe those that don't go on to have this chronic relapsing remitting disorder. There's an old idea, the distinction between endogenous and exogenous depression. It has been very difficult to really identify who does and who doesn't have endogenous and exogenous depression. So that as a start. So I think from that, the notion that depression is associated with these, aversive negative priors makes sense when you take this kind of chronic view. And then, again, I'm not sure we have very good models that capture the longitudinal course so well. But the idea is that then some of the fluctuations really happen through the environment, the interaction with the environment. So we know a lot about the fact that negative life events can precipitate depressive episodes, but less is known about the fact that positive life events are very good at ending depressive episodes. And so, it might be that part of that, has to do with that.
I think the question was, how do you model it?
How do we model it? We don't have good models.
How do you model the chronic aspect of it?
Yeah, we don't really have very good models of the longitudinal course of it. I mean, the way you would have to model it is in some sort of, dynamical system of some sort. That's what we would have. But, there aren't that many good models of it.
Quentin, I'm going to have to go.
Fair enough. So will I.
I hope it was really awesome.
Thank you for the questions and the program.
I hope you understand. I hope you understand that the back and forth is very much in the spirit of the salon. Yeah. And yes, I do think what is really interesting here is, just to summarize, it's very interesting to me to wonder whether psychiatric illness really will end up being a lot of these automated, subpersonal, algorithmic disorders. That psychiatry really is just another kind of algorithmic disorder, right? A skewed cost function, some problem, versus really not being a disorder of semantic content and representation, where you can have a chat and dissuade people from thinking they're the King of Spain, or that they should keep dating people half their age, or all the things that people tend to do. And it's just interesting to me whether there are going to be two psychiatries, a kind of much more meaning-based, talky version, which is the milder conditions, maybe even the kind of therapy that healthy people undergo. And that a lot of the really serious conditions, OCD and depression and other such things, really will become subpersonal algorithmic disorders that are subject to non-meaning-based interventions. It may not be drugs anymore. It may be some kind of training. It may be brain stimulation. But it does seem to me that psychiatry is splitting into various flavors. One flavor is very susceptible to computational modeling, and the other one is very resistant to it. And I think it would be nice to have a meta theory about why some types are resistant and others are not. In other words, could one actually a priori almost predict where you're going to have trouble? And that territory, which is going to be hard, whether it's delusions or ruminations or whatever, that we could sort of say why it's not going to succumb. And is it similar to, people like we've discussed, like Bengio, saying we just don't have system 2 in AI. We don't know how to model system 2-like things yet. We have to presuppose them, right? And then model the switching between them, presupposing them. And I'm just wondering whether that's where we're at. It's just a very interesting juncture about the two psychiatries. And maybe the form that you're doing is closer to behavioral neurology.
Wait, John, would you be okay with the idea that if I kind of captured everything you have ever written, including like emails, etc., everything, tweets, and then I made like a word embedding of certain words, concepts that you have associations with when they come up. And then I started to have like a John simulator. And let's say, just hypothetically, that you have a depressive episode, and then you start saying certain things. And then I can sort of have a model of what your rumination might look like based on applying a particular model to that, let's say, embedding. Would you consider this a version of that second psychiatry, or still a version of Quentin's psychiatry?
No, that's a really good question. I think that if the content began to take on a kind of predictive, automated life of its own, where it became almost habitual, I think that it would then become more like David Beddar's hydraulics, more like what Quentin is doing, that it would become subject to the first kind of psychiatry. I think you're absolutely right. And I think that's the point that Quentin is making, is that almost anything can become sort of algorithmically dumb. In other words, you can begin...
Although I wouldn't say dumb. There could be different levels of that, right? You could have algorithmically dumb things, or even more. So another question, John. So what about patterns? Let's say that I don't know the exact content predictively that you're going to say, but I know what patterns are going to emerge. So if there is a new content, I have like maybe this template like grid fields, but for your conceptual space, that I know, oh, when John gets drunk or when John gets depressed, this is the trajectory of space that like, or this is the kind of patterns I can see in his thoughts versus when he's not depressed, right? Yeah, would you consider this Quentin, or would you consider this the other? Because I think it's in between. I don't think it's like entirely content free as you're suggesting.
Exactly. I mean, that's just the question you're asking, Ida, is kind of just where I wanted to get at, right? I'm not claiming I know. I'm just saying that I think it's just a difference that makes a difference. In other words, I think there's a difference there that matters, right? Yeah, that's what I'm saying. I'm saying, so for example, you're absolutely right. I mean, Kahneman makes this point that, you know, you can go into a bar and behave in the typical way. Oh, there's John doing exactly what he always does. That's his type. That's what he always says. That's what he always does. And then, of course, I could say, well, this particular person was really interesting, and it was their particularity that really mattered to me. But everyone knows, no, this is just the same old pattern over and over again. And then you could say, well, which one of those is that? Because if you were to do behavioral therapy, you would exactly do what you're saying. You'd say, look, John, do you see these patterns keep recurring? Do you not see that there are certain invariances in your behavior? You see that your excuses about the particularities really are sort of, like Quentin said, surface differences, but there's something far more generic going on underneath. Then I think that it would be more Quentin-like. Now, I think the point you're making, Ida, is it feels like it might still be a little bit out of reach of the kind of tasks that Quentin is talking about, and the kind of, but it does seem somewhere in the middle. I agree with you. It seems, at least those patterns that people do, like the one I'm describing, seem to be amenable to talk therapy. It seems as though a therapist can point out to you patterns that are recurring, even though you think there's no pattern there. So to the degree that you can be persuaded through the meaning of the word pattern, and do you realize you're doing the same thing, it feels like it's somewhere in between. But maybe that intermediate thing, Ida, would be where it would be amenable to the kind of modeling that Quentin is doing. Maybe that would be the first foothold on that murky intermediate territory where it's still content-based, but it still seems to be not full content. You know,
right.
Maybe that's where you go. Yeah.
So maybe it captures some broad brushes about the generalities of the content.
Yes.
Yeah.
And I think that's what psychiatrists typically do.
And what I'm trying to say, John, is that, and I put a model in the paper in the chat where me and Bill Sivers started to create such a thing, not for psychiatry. That one, we just tested it on particular memory phenomena of forgetting and remembering that exists. I would say, John, if I wanted to bet, I would say the way psychiatrists right now talk with someone for like many sessions, and then figure out what could be the recurring patterns, and then figure out how to recreate the situation and make the person feel safe about it or unwind the pattern, all of that. I mean, I know Eliza already has had this kind of themes in the 70s or 60s. I don't know when Eliza came out. But I do think that can be automated. And I do think if we have a good model of mental illness, we can model that kind of therapeutic relationship, even with the content. I know this might trigger Melanie because this is her. This could be Melanie's, like, what was that series, like Black Mirror episode? But and I'd love to hear what Melanie thinks. But John, I do think it's possible in principle for many, many situations where people actually could really use that help for them to identify.
I absolutely agree that it would be very interesting when a therapist points out recurring patterns that you aren't aware of. You believe that each event is particular, and then a very insightful therapist, she tells you, well, in fact, there's a pattern. And then whatever that pattern is, whatever's going on, it then can be gone. You could dig down one level lower and do what Quentin is doing and come up with a kind of computational model of the kind of automated, recurrent behavior that you're engaging in that actually does divorce itself to some degree to the content that you only post hoc use yourself. That's very interesting. I'm not aware, Quentin, maybe you could say whether that kind of behavior that's still amenable to talk therapy has been modeled. In other words, is that kind of abnormal patterns where people keep doing making the same bad life choices, is that amenable?
Well, I think that's
tell me
like
if this is something. So one thing we did is, in the context of behavioral activation therapy, what we had people do is we had them schedule, things they wanted to do. And we asked them, how much do you look forward to this? And then they did them, and we asked them, so did you enjoy it or not? And they told us how much they enjoyed it. And then the next time they scheduled it, we asked them again, so how much do you look forward to it? So the extent to which they looked forward to these various activities changed, according to the prediction error. If the reward, how much they said they enjoyed it, was more than what they had said they expected it, then next time around they expected it to be better than the previous time around, and they started doing it more. Now this is very low level in a sense, right? This is basic behavioral reinforcement, really basic, right? But it seems to structure the kind of how people choose to behave through the day, what kind of activities they choose to go after. So I don't know, to what extent is that relevant or not?
So I don't think that's like particularly related to what we were just talking about. But John, I want to say that's the kind of computational psychiatry that I would be interested in. And I thought of calling it something like cognitive map therapy, because at the end of the day, the goal of that approach would be to identify what is the underlying model that this person is applying to different situations. Like it's almost like a convolutional filter that you have, and you see every situation through that filter, and it's almost like you're looking for people who play the roles you want in this narrative that you keep repeating. And in every situation, somehow you push people until they play that role with you. That's something that's very interesting to me that I see recurring. And watching like even some shows, that's how they get to portray somebody who's like a very good villain or a very good smart whatever.
No, I get exactly what you're saying. I mean, that would be, maybe that will be the next step that we'll do.
So imagine that would be like identifying a person's internal cognitive maps, not for space, but for social interactions. They're kind of templates, not for airports, not for, the same way you have a schema for airport. Now everybody has issues with these words, like let's use them loosely just because it's late. So the same way you have a schema for airports, every airport is different, but you know where to go. Likewise, there could be some schema that people get stuck in, and they are like generalized versions of cognitive maps that they might have encountered in heightened states of.
They get stuck in the same play over and over again.
Exactly.
Right?
It's bizarre because it's really performance. It's really like a play, and the way they perform it with passion, with like complete emotion is interesting, right? So I think that kind of a thing that's completely not basic, not easy, I think that can be even that can be sort of modeled. And I do agree with you. There is a spectrum. Not everything can be maybe computational psychiatrized, but I do think even that case, and that's the kind of thing I'm interested in, even that, using some of the more advanced kind of like, modeling approaches, we could get there. I don't think we can't get. I think that's the difference that I thought you thought we can't get there because you thought, oh, the models.
I was seeing a dichotomy.
One interesting aspect of behavioral activation, the stuff I told you right now, is that what predicts whether people respond to it, interestingly, is their thinking patterns. It's not necessarily their behavior, but it's their thinking patterns. It's the thinking patterns that change with these kinds of interventions. So, it's hard to take a hard and fast and say, this is simple, this isn't complex, this is a map, this is just basic reinforcement behavior. It's not that simple. These things interact in really interesting ways. And the way we can intervene on one versus the other, we can intervene on one and affect the other in interesting ways.
Well, I'm going to go, and all I can tell you is I'm not in my office because I'm noticing that all three of you have lots of books in the background, and I don't. But this is not my office.
No, that is this actually.
Oh, we were judging you, John.
These are my non-science books.
Let us judge you.
You have wine. You have wine, and we don't.
Look, big hugs to all three of you. Quentin, it's so lovely to see you after all this time. And Melanie and Ida, welcome back.
Indeed.
Quentin, we couldn't have had a better reopening of the salon than with you. It was awesome.
Thank you so much.
See you, John.
Bye.
Melanie, please go ahead.
Oh, well, I was going to say about the notion of like seeing patterns in people's behavior. We humans, of course, are notoriously prone to see patterns even when they're not there, especially ones that kind of resonate with our prior beliefs. And I think there is some danger in the notion of finding patterns that aren't there and convincing people that they are there. And I've, seen this in various people's psychotherapy experiences, and it worries me. And maybe you'd have to do some kind of sort of random controlled study where you have one therapist who's like talking about not patterns that aren't there and trying to convince the person, and another one who is trying to see patterns that really are there and see what the response is. But people can be convinced that they're falling into patterns, if someone tries to convince them of that.
Yeah.
So it just worries me a little
anything
bit.
can be worrisome. Like you can use a knife for cooking, or you can use it to kill someone. And you can accidentally use a knife to cut something, but cut your own hand. I totally agree. But what I'm asking, do you really think there are no cases where there is actually a pattern that people from the outside can see in a person, but they can't? And when this person becomes aware, as long as you think it's possible, all I'm saying is let's model it. Now, with how it's being applied, whether it's being applied ethically, whether it's being applied with a sense of consensus, whether it's there's going to be verifiable things, it's ethics. I'm totally down for it once there is even a model to do it at all, right? So I totally agree with you. There should be many controls to see, is it going to find relevant patterns? Is it going to potentially have some kind of an idea of what are the relevant sort of things to even look for? Like if it's something that's working for the person, that pattern could be actually helpful for amplifying it.
I'm thinking specifically, back in the 1950s, there was this idea that autism was caused by the mother not loving the child or being cold, and so there was a lot of psychotherapy based on that where the mother would go into psychotherapy, and the psychotherapist would find patterns of the mother's behavior that showed why the autism in the child was occurring. And then later it was found to be total BS.
But the problem was not the patterns he was finding in the mother. The problem was the link between those patterns and the autism of the child. Let me add something.
I think that's wrong.
Again, the question is, the DSM also used to consider homosexuality a mental illness, and they used to lobotomize people who were depressed. It doesn't mean that the entire, everything that had ever been done was completely now, we have to throw everything away because there have been errors, right?
No, I'm just, all I'm saying is that we have to be careful about.
Yes, totally got that message. Now let's come back to the main point. Got the message. We have to be careful. Do not lobotomize homosexuals or depressed people. Let's come back. What is, do you think it's impossible for a model to be able to discover helpful patterns using a person's therapy session scripts?
No, I think it's certainly possible. And I think, it might be, even if you find bogus patterns, maybe that will help.
I'm not really claiming that. So we're on the same page in terms of it's possible, right? And then I wonder, is it possible to do it the way that an average therapist might do? And then another question I have is it possible to figure out, because as you know, for instance, cognitive behavioral therapy, 50% of the time works, does or doesn't work. Like you don't know when it's going to work. And you don't know what are the parameters that makes it work or makes it not work. And so it would be very helpful to just find a way to analyze many hours of therapeutic sessions for similar conditions, different conditions, and figure out what were the patterns that helped in the cases where it worked. And what were the patterns that didn't work? It's not going to be the same thing. It's going to be this multidimensional, messy space, of course. But that's the direction I'm thinking, not the direction of, all right, I'm going to give my mental health in the hands of an app. You know what I mean? And I'm very with you on all of the concerns. But those concerns obviously apply, as you correctly mentioned, to the history of psychiatry itself. We have to be very careful about how much we put credence into the time, the zeitgeist of what is illness. And like I was mentioning in the chat, I think Michel Foucault's History of Madness or Madness and Civilization depending on the translation that you get, is a very good, interesting book where it's looking at the kind of the history of the notion of mental illness in some kind of like, you know, barbaric treatments of people with seizures or with depression in like earlier centuries, and how that from imprisonment and mental illness started going hand to hand, and how that changed. He died. He didn't see the rest of it get better. He died when I think people were still being lobotomized. So yeah, so that's what I'm trying to say, that it is in principle possible, while I am 100% with you, being careful of the outcome of any psychiatric theory, whether it's administered by a person or a machine, and especially be careful of the errors that a machine can make that could potentially be dangerous. Totally with you. But I think that we have come far away from where John was initially, which was we can't do anything with these things computationally, right? At least we got to a point where, in principle, maybe we could model some of those things that John talks about in terms of content. I don't know if you agree.
So I'm really sorry, I may have to leave soon. It's just getting quite late. You know, I think it's not because we can't do everything that we should throw the baby out with the bathwater. There's lots of applied things where we can make a difference, and they're really quite useful. There are patterns we can discover. We use them a lot. We know a lot about the patterns that are helpful in psychotherapy from, you know, the typical, what people do in psychotherapy. They videotape themselves and analyze it and look at that. That's being done on a much larger scale now with, you know, online services, etc. So that those patterns are you know, there is method to illness often, and those methods and patterns, they can be used, exploited, identified, modified, and that can be useful. It doesn't mean that all is only that. It doesn't mean that, you know, the other aspect is not helpful and cannot be attained. But it's a step, right? It might be a first step, but we have to take it. Okay.
Thank you so much. I know it's very late there by now. What time is it actually? It's past midnight?
11.
Half past, so very close to midnight. So thank you so much. I don't think I would personally be very likely to accept such late things. So we really appreciate it, especially since it's so dialogue heavy and we are all very kind of, as you know, energetic personalities. Really, thank you. Huge fan of your work. And I look forward to interacting on computational psychiatry and other things in the future. Thank you, Melanie, for your insights. And thanks everyone for comments. Yeah, join us next time. I think we didn't post the program yet, but I will post the full program. We have very exciting speakers, including Yasha Bengio next year. Yeah. Any other last words, Melanie or Quentin, before we leave?
No, this has been great. Thank you so much, Quentin. Bye-bye.
Thank you so much. Thank you. Bye.